All right, engineers, in this video, we're going to talk about the diagnostics that we should run on patients potentially who have COVID-19. Let's go ahead and get started. All right, so when we're diagnosing patients with COVID-19, we need to start with their vitals. That's really important. What are we looking for? We're looking for any signs of hypotension. Well, what do we consider hypotension? Well, really, that's whenever they have a systolic blood pressure that's less than 100 millimeters of mercury, right? That might tell us that, oh man, these guys might be septic. That's not good. The other thing that we want to look for is, are they hypertensive? So are they having a systolic blood pressure or a diastolic blood pressure, systolic greater than 140 millimeters of mercury and diastolic greater than 90 millimeters of mercury? Why is this important? Well, this is a risk factor. This increases the risk for these individuals to become super sick. So those individuals who have hypertension, they're at higher risk for serious infections with this COVID-19 disease. The next thing we do is we want to check their heart rate. Are they tachycardic? Potentially that could be one of the signs because they're hypoxemic. That's a tachycardic drive. So one of the other things is look for any signs of tachycardia. And again, that's just basically increased heart rate. Anything greater than or equal to 100 beats per minute, right? Next thing, we also want to check their respiratory rate. Are they breathing really rapidly? Are they breathing very slow? At what point are they in this situation? So the other thing that we want to look for, are they breathing really heavy and really rapidly? And that could be a sign of what's called tachypnea. And tachypnea is an increased respiratory rate. Let's say that they're breathing greater than or equal to 22 breaths per minute. So that's another sign. The next thing we want to do is check their temperature. So do an oral temperature, check to see if they're febrile. Are they showing signs of a fever? We consider a fever, the standard, as being greater than or equal to 100.4 degrees Fahrenheit. So basically kind of starting off in triage, is the patient hypotensive? Are they tachycardic? Are they tachypnic? Do they have a fever? Do they have any other comorbidities, like any other conditions like hypertension, COPD, and are they older? If they are, they might potentially have COVID-19. So next thing let's do is let's do a physical exam on them. The next thing we want to do is we really want to auscultate the lungs. We want to listen because we know that this disease, COVID-19, caused by the SARS-CoV-2 virus, can cause a lot of lung damage and acute lung injury, potentially pneumonia. Listening to the lungs is really key. So if we auscultate the lungs, what are some potential things that we might hear? Well, if someone has pneumonia, sometimes they can have what's called breath sounds, particularly bronchial breath sounds. And that's an indication of potential consolidation. So you want to listen, do they have any higher pitched breath sounds called bronchial breath sounds? And again, this could be indicative of consolidation, maybe pneumonia. You also want to listen, do they have any wheezing? Are they having some bronchoconstriction? Are they having any kind of like mucus plugging? Because that wheezing could be indicative that maybe there's some type of either mucus plugging or there's severe bronchoconstriction and not a lot of air is getting in or out. The next thing that we also want to listen for, is there any crackles? Okay? And crackles is important because there's two types. You can have what's called fine or coarse. Regardless though, you're listening for crackles because this could tell us that there might be some alveolar edema, there might be some fluid that's accumulating within the lungs, and that might be a sign of, oh man, this is not good. They could potentially have pneumonia, they could potentially have some fluid accumulation in the lungs. So not only can they have this, but they also might have some mucus secretions within the airway, and that might produce kind of a snoring sound, and that's called rhonchi. And lastly, if you want to do some special tests, you can. And some of these special tests is you can check for what's called egophony or what's called bronchophony. And these are special tests that we talked about in our pneumonia lecture, if you guys want to go and watch that, okay? So, if we auscultate the lungs, we hear any bronchial breath sounds, wheezing, crackles, rhonchi, anagophony, or bronchophony, that might increase our suspicion of COVID-19. Because of that, what we're going to do is, and maybe their symptom presentation, we're going to start off by swabbing them. So we're going to do what's called a nasopharyngeal swab. We're going to take the swab, stick it back into their nasal cavity, twist that to get some cells and some mucus from that. Then once we take that swab, we're suspecting that the virus is present within that swab. And what we're going to do is we're going to do what's called a PCR, but a very specific type of PCR. The type of PCR that we're going to run is called reverse transcription PCR, which is polymerase chain reaction. What does this mean? So let's say that we took the sample and let's assume that it has the SARS-CoV-2 virus in it, okay? What we're going to do is we're going to isolate the nucleic acid out of that virus, which is the RNA, okay? Then PCR, you need to basically amplify and make more DNA. Well, this is RNA. How do we get RNA to go to DNA? Well, I'm glad you asked. We have a special enzyme called a reverse transcriptase enzyme. And what this enzyme does is it takes and converts RNA into DNA. Because what is transcription? Transcription is DNA to RNA. What if I go in the reverse direction? Then it's RNA to DNA. So what I'm going to do is I'm going to convert the RNA into DNA. And again, this is the viral RNA from the SARS-CoV-2. Now that I have this DNA, and we're actually going to call this cDNA for complementary DNA. I'm going to basically take this DNA and I'm going to put it into this solution. And in this solution, what I'm going to do is I'm going to add a bunch of stuff. I'm going to add these things called primers. I'm going to add in what's called nucleotides. And I'm going to add in some enzymes, a particular enzyme called Taq polymerase. And then what I'm going to do is through the process of PCR, polymerase chain reaction, is I'm going to denature the DNA, then I'm going to do what's called annealing, and then extend it and make, through that process, tons and tons and tons of DNA. So now I just made tons of DNA. Now, we basically put little color molecules, we put little fluorescent components on either the primers or the nucleotides. And if they're present within this DNA, they'll give some color whenever we run this PCR test. And if the color is detected by the PCR machine, that tells us that the DNA is there. And that means that if the DNA was there, that means that the RNA had to be there. And that RNA came from the SARS-CoV-2 virus. So this could tell us we had a positive test. Okay? In the same way that we could do reverse transcriptase PCR, we can also, and again, this is basically going to be swabbing for SARS-CoV-2. So again, you're using RT-PCR. They consider this to be the gold standard at this point in time. Here's the issue though. They're getting low on testing because it's being utilized so much. And in addition to that, it has a sensitivity of somewhere around approximately 70%. So it's not amazing, but it's good. It's okay. So what they're thinking is that what we can do with this is there's what's called a pooling method. And we're going to have a link down in the description box where you guys can go check that out. And this is basically going to be utilized, hopefully it was utilized in Germany. And it's basically where we can take swabs from multiple individuals who potentially might have the COVID-19 and add all of their swabs into the same sample and run it. And again, I'm not going to go into crazy detail on it. We'll have a link in the description box if you guys want to go read and check that out. But hopefully it's going to save us on utilizing excessive testing kits. The other thing that we're trying to do now, and again, is rule out other types of viral conditions. So we can do what's called a respiratory viral panel. And basically we're taking swabs, we're taking sputum, And we can test for multiple types of viruses. Like what? Well, maybe we want to check to see if they have influenza. Maybe we want to check to see if they have RSV. Maybe they have parainfluenza. Maybe they have rhino or adenovirus. So we can do the same kind of thing where we can run PCR on various other types of respiratory viruses because we want to rule out that those are not the causes and maybe potentially it is the SARS-CoV-2 virus. So now that's one thing. We can do this swap, but again, I want you to remember that there's a sensitivity of 70%. That leads us into the next thing that the research is showing. We can add in what's called serology. And what this serology can do is if we combine serology with the RT-PCR, the sensitivity can increase to almost 99%. So let's talk about serology. All right, so in order for us to understand serology, we have to understand a little bit about the antibody production that's occurring with COVID-19. Now, we didn't talk about this in the pathophys lecture because I wanted to bring it up here. Now, remember, in the lungs, you have these macrophages, right? The alveolar macrophages. And potentially, we're going to have this SARS-CoV-2 virus there. One of the things that we know is that the macrophages can undergo what's called a phagocytosis process where they engulf the virus in. So they can undergo what's called phagocytosis. And they can engulf the virus into the cell and put it into like a little phagosome. Then what happens is it combines with the lysosome and breaks down any components of the virus. And then what it does is it secretes these, the chromosomes on chromosome number 6 produces these proteins that bind with particular antigens on the virus and expresses it on these MHC2 complexes. And again, here's the antigen. The particular antigen that we're focusing on is called the S protein. Then what happens is after the macrophage expresses the MHC2 complex with the S protein, it takes it to a nearby T helper cell. This T helper cell will then have a TCR, which is specific to the S antigen, and a CD4 positive protein, which is specific for the MHC2 complex. When these two interact perfectly, it triggers the T helper cell to release a massive amount of cytokines, specific types of interleukins. These cytokines then alert our B cells, our B lymphocytes, and tells the B cells to start proliferating and differentiating. So again, what happens? They undergo what's called differentiation. And this differentiation converts the B cells into what's called plasma cells. And these plasma cells are very specific because the cytokines, not only do they trigger proliferation differentiation, but they also stimulate the plasma cells to start making antibodies. What kind of antibodies? Well, these antibodies are specific. So it's going to trigger what's called antibody production. These antibody production is basically designed to bind to the specific antigen that it originally focused on, which was the S protein present on that SARS-CoV-2 virus. And basically the whole goal of that is to trigger an immune response to enhance phagocytosis, activate the complement system, basically eradicate the virus. But this helps us with testing. Why? Because these antibodies, whenever you're first initially infected, you produce a very specific type of antibody called IgM antibodies. And these tell us that you are actively infected. So this indicates an active infection. The next thing is we're going to test for the other types of antibodies so you can potentially test for. And these antibodies are made a little bit later. Okay, over time, these antibodies, what happens is the antibody production switches from IgM to IgG, but this takes some time. So again, the antibodies that we're going to produce later are called IgG antibodies. Now, these antibodies indicate two particular things. One is that you basically have recovered, you had a recent infection. So you recovered from the infection and now you have some type of immunity, or again, it indicates a past infection. And that is important when it comes to determining, is this person now immune? Do they have some sort of immunity against this virus? Because maybe now they can go back into the workforce. Maybe they can go back to their job. Maybe they don't have to self-isolate anymore in their house away from their family. So that's what's really interesting about this. Now, the only thing that we have to remember is that this antibody production takes time. So if someone basically develops symptoms, they might not have a positive antibody test initially. It might take potentially up to a week before these antibodies, particularly the IgM antibodies, are produced. So that's one of the potential disadvantages of these tests. But if we combine it with RT-PCR, they have a great sensitivity. All right, so what we do is we take some blood, right, from particular patients. Let's say we have 3 patients. We take some blood from them, and we take that blood and we put it on these little test strips. They're these little test kits. And basically what happens is, without going into crazy detail, you put the blood into the sample and then you put a buffer solution in here. And what happens is, this is going to do what's called a lateral flow. And what happens is the antigens and antibodies that are picked up either on the conjugate pad or that's in the sample is going to run through what's called this nitrocellulose membrane. And as it runs through, it might get picked up by the capture antibodies in these particular test lines, whether it be the IgM capture antibodies, IgG capture antibodies, or the control antibodies. In order for this test to be considered valid, the control line has to come up positive. Okay, because that means that whatever solution, whatever like biomarkers or gold or antibodies that were here, control antibodies, they came up and were captured by the control antibodies. So this has to be positive. So that's the first thing to remember. If this comes up positive, okay, we have a valid test. Let's say we run it on patient number 1 and they get no hit. There's no line that shows up on the IgM test line, no darkening of the IgG line. What does that mean? Well, it means that they have no infection because they don't have an active infection or they don't have a past infection that they recovered from and have any immunity from it. So this is negative. So this shows us that they have a negative test and that there is no infection. The next thing that we can do is, let's say that we take patient number 2. We put their blood into the sample, put our buffer solution in, and basically what will happen is this lateral flow immunoassay, these molecules will run through this nitrocellulose membrane and bind to the capture antibodies. Now again, we need the control line to come up positive in order for it to be a valid test. Let's say it comes up. Okay, it's valid. And then, it comes up IgM positive. What does that mean? Well, that means that they're positive for a particular type of infection. What type? They have an active infection. So this could indicate active infection. Okay, let's move on to the last one. Patient number 3 comes in. They get their blood drawn, a little pin prick there, right? So we do a little finger stick, we put the blood onto the sample, we put our buffer solution in. As we do that, what happens? We want the sample and the buffer solution to move through this nitrocellulose membrane and get picked up by the capture antibodies. In order for it to be a valid test, we need the control to come up positive. So let's say that the control comes up positive. We look, IgM doesn't come up positive, but IgG comes up positive. If the IgG comes up positive, what does that mean? Well, that means that this test is positive, but it's positive for a past infection and that these individuals might have an acquired immunity now. So this might indicate recovered or past infection, right? And again, that recovered means that they might have some form of immunity against this virus. That's one way, okay, that we can do this. This is quick. This is something they can do in the ER at point of care. This other test is a little bit longer and it tests a larger population. So this is more for epidemiological data as well as helping us to develop treatments. So neutralizing antibodies from people who have either recovered or they were asymptomatic and that they've developed an immunity to this. So this is more for epidemiological data as well as helping us to develop treatments. What is this called? It's called ELISA, but the overall concept is the same. We're looking for antibodies. ELISA stands for enzyme-linked immunosorbent assay. Now, what happens? We take a blood sample, right? And from that blood sample, let's say that we have the SARS-CoV-2 virus there, right? And a particular protein that we're focusing on is that S protein, right? From the blood, the sample gets put into this little well. And let's say that these red proteins here, again, this is indicating the S protein, all right? These green proteins here, they have a very particular function. I'll explain in just a second. We put the S proteins, or these S antigens, they get put into the well and they bind on to surfaces of the well. Generally there'll be some empty spaces there. We don't want that, because what can happen is enzyme-linked antibodies can bind onto those empty spaces and give what's called a false positive. So what we do is we put into the sample some non-specific proteins. Okay? And what these non-specific proteins do is they just take up space. So they bind into the empty spots so that the enzyme-linked antibodies don't bind there and give us a false positive result. Then what we do is we add in the primary antibody that we're looking for, the IgG antibodies from the recovered individuals, hoping that it'll react. So now we're going to add in the IgG antibodies, and these are what's called our primary antibody. We're going to add this into the solution. The goal is that these primary antibodies react and bind with the S protein of the SARS-CoV-2 virus. If it binds, then what we do is we add in another antibody. This antibody is called an enzyme-linked antibody. So we call it an enzyme-linked antibody. And when this enzyme-linked antibody is added into the solution, it loves to bind to the portion of the antibody, the constant portion of the antibody on the end, right? When it binds there, it becomes activated. Now, here's where the test either becomes positive or negative. The next thing we do after we've added in the enzyme-linked antibody is we add in what's called a chromogen. And all this means is that it's going to give us color. If the chromogen is added and this enzyme-linked antibody is bound to the primary antibody, which is bound to the SARS-CoV-2 S protein, when this chromogen is put in, the enzyme-linked antibody will break down the chromogen to where it gives color. And if it gives color, that'll be picked up by the ELISA reader or the spectrophotometer. So if there's color that's generated, what does that mean? It's a positive test, and it means that these IgG primary antibodies were present and were able to react with the spike protein. That is important. So again, if we get a color, this is a positive test. The brighter the color, the brighter the concentration as well. So again, these are the serology tests that we can combine in addition with the RT-PCR, but if you want point of care, it's rapid. For more epidemiological data, it's ELISA. Another vital that you're going to be measuring in these individuals is what's called the SpO2. It's just a little thing that you put onto their finger, and it tells us somewhat of their percent oxygen saturation. Well, in this situation, sometimes if the individual has what's called a low SpO2, all right? So let's say it's like less than 93% on room air. That might make us a little concerned, because normally we want that thing to be up around 97, 98, 99, 100, right? But if it's starting to get low, that might concern me. So let's say that it's really low. Let's say it's like 90%, but in general, we're saying it's less than 93%. That might concern me. And if they're showing all these other symptoms and they have maybe some positive tests, I might want to run an ABG. Let's see why. In those situations, remember we said before that the lungs are responsible for allowing for gas exchange. Well, one of the things that we worry about is that with that acute respiratory distress syndrome and a lot of that consolidation, we worry about less oxygen being within the blood, hypoxemia. We also wonder about the CO2 concentration. Is it elevated or is it decreased? And this depends upon, are they breathing really rapidly to try to clear it, or are they breathing really slowly because their lungs are starting to fail, their muscles are starting to fail? The bicarbonate, is the bicarbonate high or low? Well, that could depend upon compensation. Is the proton concentration high or low? And again, that depends upon the CO2 concentration as well as the bicarb. So whenever we do an ABG, what are we looking for? Well, there's three potential things that can happen with these individuals. One is called respiratory alkalosis. This is something that we might see initially, in the initial stages. Why? Let's say that they have some ability to increase the respiratory rate. As you are increasing the respiratory rate, they're tachypnic. What are they doing? Well, they're breathing out more CO2. Now, if they're breathing out more CO2, what happens to the PaCO2 within the blood? It can start to, what? Decrease, because you're clearing it via exhaling so much. So one of the things that might happen is you might have a decreased PaCO2. Now, Because there's less CO2, do you guys remember that formula? That CO2 plus water yields carbonic acid, which breaks down into bicarb and protons. If there is less CO2, what happens? Well, the reaction starts kind of shifting to the left. That means the proton concentration starts decreasing. And that means that the pH starts going up. So the potential here is that there might be an increase in pH. Now the bicarb at this point in time, it depends upon compensation, so let's not worry about that right now. Also, if they're not getting enough ventilation, they're not getting enough oxygen moving in from the alveoli into the blood, what potentially could happen to their oxygen saturation? That might also be lower. So they might have a decreased partial pressure of oxygen in the arterial blood. This could be a sign of respiratory alkalosis. Maybe over time, as the muscles, so as someone starts having ARDS, maybe their muscles, their external intercostals, the diaphragm muscles, they start getting really weak. And fluid, so not just muscles becoming weak, but so much fluid is accumulating between the interstitial spaces. So now the ability to clear CO2 might start decreasing because the muscles are so weak, they're not able to breathe properly. You're not able to exhale that CO2. There's so much fluid that's blocking the gas exchange. So PaCO2 might start rising. What does that mean for the equation? Well, that means that, again, go back to this equation here. If this is occurring, we know that the reaction will shift to the right as CO2 concentration increases. That means we'll make more protons. As protons increase, the pH starts to decrease. And this is a sign of acidosis. On top of that, if the muscles are getting so weak, there's so much fluid accumulation, and we're not getting oxygen across that alveoli, we're not getting oxygen into the blood, and there can be decreased partial pressure of arterial oxygen, showing signs of hypoxemia. And again, let's not worry about the bicarb at this point in time. The last thing here is that someone starts to potentially become septic, right? Maybe they're having some signs of sepsis. Then what can happen is not only will the PaCO2 potentially be affected, but the bicarb might also become affected. In what way? Well, as potentially a metabolic acidosis arises due to sepsis, what happens is the bicarb concentration might start dropping. As the bicarb concentration starts dropping, what does that mean? Well, that means that you're losing a lot of your base. And if you're losing a lot of the base, what does that mean for the pH? Well, that means that the pH is going to start to become more acidic because as you lose base, the more acid ions are going to prevail then. On top of that, again, you're still having a difficulty being able to ventilate the lungs. So there could potentially be a decreased arterial partial pressure of oxygen, and because you might not be able to clear CO2 from the body as well, there might also be an increased PaCO2. All right, so now we've done an ABG. We found that they could be respiratory alkalotic, they could be respiratory acidotic, they could be metabolic acidotic. The next thing we should do is we should order other labs just to get an idea of what could be going on and what can this tell us. Well, the first thing let's order a CBC. And what a CBC might show us in these individuals who have COVID-19 is that they have low platelets, and this is called thrombocytopenia. So that could be one sign. So one sign here could be what's called thrombocytopenia, low levels of platelets. The other thing that the CBC might show us is that these individuals have low levels of lymphocytes because they're fighting off this infection. And this could be what's called lymphopenia. This is another common thing that can come up. So again, we order a CBC, which tells us the activity of someone's bone marrow, and maybe we order it with a diff, which is a differentiation telling us the different types of white blood cells and their numbers. And we might see from that some thrombocytopenia, low platelets, as well as lymphopenia, low levels of lymphocytes. The next thing we do is we order a CMP. And a CMP is going to tell us our electrolytes, it's going to tell us our glucose, it's going to tell us our kidney function and liver function. Well, let's assume that the liver and the kidney have been damaged either directly through the cytopathic effect of the virus or due to that multi-system organ failure effect. Because of that, the ability for the kidney to clear urea and creatinine from the kidneys is going to decrease because they might have decreased urine output. So because of that, there might be an increase in the urea concentration in the blood, as well as there might be an increase in the creatinine concentration in the blood. And this could be a pretty, not a really good thing that we want to see in someone who maybe is having decreased urine output and potentially kidney damage. The other thing is if we order a CMP, we can get some liver function. So it might be able to tell us our LFTs. So we can get kidney function, but it also can tell us our LFTs, our liver function. And with that, we either due to the cytopathic effect of the virus or due to the massive decreased perfusion to the tissues, there may be some elevated AST enzymes as well as some elevated ALT enzymes. Okay? The next thing, whether it be due to the cytopathic effect of the virus on the heart or due to that, again, that multi-system organ failure-like effect, there can be damage to the cardiac myocytes. When the cardiac myocytes are damaged due to this virus or due to decreased perfusion, it can leak out particular types of molecules and enzymes. What are some of these? Well, one is called creatinine kinase, and this is MB, which is specific to the heart, and this may be elevated, showing signs of cardiac myocyte damage. The other one is troponins, troponin I and troponin T, and these are also maybe indicative of potentially cardiac myocyte damage. The next thing we're going to want to do is you can order what's called a procalcitonin. Let's say that you think that the patient has the viral pneumonia, okay, due to the SARS-CoV-2 virus, and you think that they might have a super infection, so a bacterial infection and SARS-CoV-2 infection. Well, in that situation, which would be terrible, they may have an elevated procalcitonin. If it's just viral, so here, if it's just viral, then it'll be normal. But if it's bacterial, if they have a bacterial superinfection with the SARS-CoV-2 infection, then it will be positive or elevated, okay? The next thing that we're going to want to do here is because we know that this cytokine storm can cause such massive inflammation and cause systemic inflammatory response syndrome, this can affect our procoagulants and anticoagulant activity. And what they say in this research is that it has the ability to increase the procoagulant activity. But what the problem with this is as you increase the procoagulant activity and decrease the anticoagulant activity, this leads to lots of clots. And as we start to form lots and lots and lots of clots, we use up those procoagulants. And our concentration of them decreases because they get consumed to make clots. And what is this called? This is called disseminated intravascular coagulation. And basically what happens in this is, again, you get widespread clots throughout the body, but you consume so much of your coagulation proteins to make these clots that now they're starting to decrease. So if you have less procoagulants, remember the procoagulants involved in the intrinsic pathway? If there's less of them, then what happens the time it takes to bleed for that pathway? It increases. So these individuals may have elevated PTT. If you decrease the procoagulants involved in the extrinsic pathway, that determines the times it takes to clot within the extrinsic pathway, and that might show elevation of the PT or INR. On top of that, if you're starting to utilize a lot of fibrinogen to make these clots, what happens to the fibrinogen concentration over time? It starts to decrease. The D-dimers, they might be elevated in DIC. And on top of that, these are your anticoagulant proteins. What do we say happens with these guys as you start to consume, as you start to have this massive cytokine storm? Well, we're trying to inhibit the activity of the anticoagulant. So we try to inhibit their activity, such as platelet activator inhibitor, such as protein C, such as thrombomodulin. And this leads to potentially DIC. The next thing that we'd want to do is order some blood cultures. Why? What if we're nervous that because of this infection, they maybe have a super infection with a fungus or a bacteria? So we should order 2 sets of blood cultures, looking for any signs of maybe a bacterial infection or a fungal infection that has become disseminated. The last thing that we can do is we can check for any non-specific markers of inflammation but are associated with a higher mortality rate. What are some of these? One of them is CRP. And CRP is basically released, it's an acute phase reactant protein released from the liver in response to a lot of interleukin 6. In addition, we know from the pathophys that there's going to be tons of interleukin 6 in the blood. In addition to that, we also have other nonspecific inflammatory markers such as elevated ferritin, elevated lactate dehydrogenase, and again, another marker of inflammation, elevated D-dimers. So these are the things that could potentially show up in the laboratory studies. All right, so now that we've talked about the labs, the next thing that you want to do, and generally, whenever somebody's coming in, maybe they're showing signs of low O2 sats, maybe they're complaining of dyspnea, maybe they even have some chest pain or pressure. The first thing that you want to do is make sure that you rule out an acute coronary syndrome or any other type of arrhythmia that they might have. How do we do that? We'll do a 12-lead EKG, and we already maybe measured their troponins as well. So we started off with the 12-lead EKG, we ordered some blood work, and we're waiting on the troponins and the CK-MB to come back. In the meantime, we're going to check our 12-lead EKG to get a baseline, see what they're at. What can this potentially tell us? Well, again, this virus could damage the cardiac myocytes. And if they damage the cardiac myocytes either directly or due to decreased perfusion due to the multisystem organ failure, this could show us signs of an acute coronary syndrome. So they may show up with a NSTEMI, a non-ST segment elevation myocardial infarction. Or they could show up with a STEMI, an ST segment elevation myocardial infarction. They may also show signs of an arrhythmia. So this is also something that we want to look for. The next thing that we want to check, and it's because of the drugs that they're looking into to utilize, like hydroxychloroquine. Hydroxychloroquine has been shown to be able to affect the QT interval. So the other thing that we want to look for whenever we're doing EKGs, not just to determine are they having any acute coronary syndrome, are they having any signs of an arrhythmia due to this virus, but are they having any prolonged QT interval. And this is where you're going to look on the EKG for the QTC. If it's elevated, we might not want to give this individual hydroxychloroquine. So again, the whole purpose of ordering an EKG is to make sure that we rule out other causes, other things that might be wrong with these individuals, as well as if we are considering doing hydroxychloroquine, knowing what their QT interval is before we give them that. All right, so now we've done so many labs. We've done some EKG, we've done some swabs, we've checked their vitals, we did ABG, we did so many things. And we suspect that maybe this individual has pneumonia or ARS or something like that. What are other things that we can do? Well, we can do imaging. So let's say that we start off with a chest x-ray and we want to look to see if there's any signs of pneumonia. Well, that's one of the potential things that might come up whenever you do a chest x-ray of an individual with COVID-19. And what that might show up with is basically what's called opacities, maybe some white areas that they might show up either in one part of the lung or both part of the lungs. So they might have what's called bilateral or unilateral opacities. That's one thing. That then can lead us to the next thing. Let's say, okay, now I want to do a CT scan. I want to do a CT scan of the chest, and specifically using my lung window, see if there's any other types of pathology there. And with this viral pneumonia, which can be caused by the SARS-CoV-2 virus, we might see what's called ground glass opacities. We might also see what's called consolidation. And we might also see a specific radiological term called crazy paving pattern. Okay? So let's say that we do that, we find that maybe they have bilateral or unilateral opacities, maybe they have some ground glass opacities, maybe some consolidation, maybe some crazy paving pattern. Another thing, let's say that we're worried because we get some of their levels back and we find, oh man, I'm a little concerned that they could potentially have like a PE or something. So what should I do in order to assure that they don't? Well, one of the things that you can do is you can do what's called a CT angiogram. particularly what's called a CT pulmonary angiogram. And what this is going to help us to do is look to see if there's any clots within the pulmonary circulation. So this can help us to look for any clots in the pulmonary circulation. And we talked about why we should do this in our pathophysiology lecture. The last thing that we can do, because basically it protects the individual from getting a lot of radiation, especially if we're having to check their lungs pretty frequently, is to do what's called an ultrasound. So point of care ultrasound. And this point of care ultrasound can tell us a couple things. One is it can tell us if there's what's called pleural line thickening. The other thing that it can tell us, besides the pleural line thickening, is if there's any increased number of what's called curly B lines. And the other thing that it can tell us is there any signs of consolidation that's showing up on this point of care ultrasound. All right, Engineers, so in this video, we talk about the diagnostics of COVID-19. I hope it made sense. I hope that you guys did enjoy it. If you guys did, please hit that like button, comment down in the comment section, and please subscribe. Down in the description box, we'll have links to our Patreon, Facebook, and our Instagram, as well as our GoFundMe. If you guys want to go check that out, we truly appreciate it. All right, Engineers, stay safe, and as always, until next time.